All right, so we're going to talk about our first type of transplant rejection here. So this is going to be the hyperacute rejection. Now, before we go any further though, I want you to just kind of organize this in your brain a little bit, because we just talked about the acute blood transfusions not too long ago. And remember, the acute hemolytic reaction, okay, so we kind of just talked about this. The acute hemolytic reaction primarily had to do with this, red blood cell major antigen incompatibility, right? That was the concept. The concept was there was some mismatch in the A, B, and O antigens. And you can go back and check that video out. We go into that in great detail. But that was the concept of an acute hemolytic reaction. Now, there's acute hemolytic reactions. There's delayed hemolytic reactions, right? But there's also acute transplant rejection. There's chronic transplant rejection. There's hyperacute transplant rejection. And so you have to kind of organize these in your mind and understand that in the hyperacute transplant rejection, you can see our red blood cell incompatibility, and we'll explain why that is in a second. This is essentially going to be very similar to the acute hemolytic reaction, though, that we talked about, if it presents this way. The pathophysiology isn't very different from what we talked about with acute hemolytic reactions. The only difference is we're transplanting some tissue, right? Allogeneic transplant, usually. And with that, there might be some HLA incompatibility and potentially some incompatibility in the red blood cells and the red blood cell antigens. Now, of course, what we would normally do to prevent this is we would do a type and screen or direct Coombs test, testing to make sure we're not going to end up having an acute hemolytic reaction or a hyperacute rejection. But the point that I want to make is that you see this with both hyperacute rejections and acute hemolytic reactions. It's the same pathophysiology. This tissue that we donated, we didn't type and screen those red blood cells to see if they had markers on them the recipient might already have antibodies against. Okay, and again, we talked about this in great detail in the acute hemolytic reaction. I don't want to belabor the point here, but the reason I bring this up is because there's also an acute transplant rejection. Okay, so there's also an acute transplant rejection. And the acute transplant rejection is not the same as these two. Okay, so this is not the same as these two. This is a completely different pathophysiology, and it happens on a completely different timeline. Okay, so my point is, I don't want you to confuse acute hemolytic reactions with acute transplant rejection. That's the big point. So it's just kind of noting these things so that you're aware of them, noting them in your mind so that when you come into those situations, you don't get confused or tripped up by it. Okay, but the hyperacute rejection is very similar to the acute blood transfusion reaction. The concept here is, when we talked about transfusion reactions, so again, I have my donor, I have my recipient, right? And essentially in a blood transfusion, right, I would be donating this blood, and this recipient might already have anti-A antibodies, right? Especially if this patient didn't have A antigens on their red blood cell surface. So if this patient was, blood type B, for example, this patient might not have A antigens on their red blood cells, so they'll probably have anti-A antibodies. And so when this donor red blood cell comes in here, right, what's going to happen? Well, it's going to get marked for destruction by preformed antibodies. These antibodies already exist. We don't have to wait to undergo class switching to form them. So these antibodies are going to bind immediately to the surface of this cell, mark it for destruction, and then we're going to end up with most likely complement-mediated destruction of these red blood cells. And because we'll have an antibody here sitting on the surface of this cell, right? If I draw it in here, I'll have an antibody sitting on the surface of this cell, right? This is going to be a type 2 hypersensitivity reaction, right? I'm marking those red blood cells for destruction. And so this is essentially what's happening with a graft, right? When I donate tissue, it's the same concept. So if you can imagine, instead of this being a red blood cell, let's just say that this is some tissue, okay? So maybe I'm donating, I'm just gonna draw a kidney in here, right? We draw some kidney in here, and on this kidney, there's antigens. There's HLA antigens. There might also be some blood in that kidney, potentially, or when that transfusion happens, there might be some blood that's transferred with it, okay? So you have your HLA antigens, you have your red blood cell antigens, right? That are all gonna be on this tissue, right? And so when I donate that tissue, the same thing can happen, right? I can have antibodies that are preformed against these HLA antigens. Instead of it being anti-A antibodies, I might have anti-HLA antibodies to specific HLA molecules that are going to be on this donor's graft, right? This is why we have to perform HLA matching, just like we have to cross-match red blood cell antigens, right? Because if we don't match the HLA markers and we start donating tissue, that host might already have antibodies to that graft. And so what's going to happen here? Well, it's the same thing as what we talked about with the red blood cells, right? These antibodies are then going to bind to the surface of the donor's graft, and this is going to lead to complement-mediated destruction. So let's just talk about this here. So again, it's destruction of the donor graft, and this is where you have to be careful. Again, destruction of the donor graft by recipient preformed antibodies, right? By recipient preformed antibodies. Again, this is a type 2 hypersensitivity because I'm putting antibodies on tissue, right? I'm putting it on the red blood cells, or I'm putting it on the kidney parenchymal tissue, or whatever it is that I'm donating. Because these antibodies are preformed, in other words, right, we didn't really do a good job of matching the HLA antigens or matching the red blood cell antigens. This is going to lead to a very rapid onset, which is why it's called hyperacute. Now, in a board question, the way that they'll ask you about this is they'll say that, a surgeon just transplanted this kidney, and as soon as there was, for example, an anastomosis created, or the blood from the recipient was then sent to that organ, what will happen is an immediate edema to the graft of the tissues. Okay, so there's an immediate reaction. As soon as this recipient's antibodies get to that kidney, it's marking it for destruction. Complement cascade is set off. So we're talking about something that's happening, again, within minutes of the graft placement. It's going to happen in the operating room. Okay, here, let's write that down. It's going to happen in the OR. Okay, so this is going to be classically presenting as they literally put that organ in the patient, it's immediately being rejected. And not only is it being rejected, this complement-mediated destruction, right? If I zoom into this kidney, okay, if I zoom in and I look at a blood vessel going through this kidney, okay, and I establish perfusion, right? This is all the recipient's blood now going through this blood vessel to supply this kidney. The antibodies here are immediately going to start to bind, right? The antibodies are going to start to bind and recognize this HLA mismatch all around this kidney tissue. And what's going to happen is we're going to get complement-mediated destruction. So complement is going to start destroying the tissue around here. We can get a little bit of an inflammatory reaction potentially, but eventually what's going to happen is from all of this endothelial cell destruction, it's eventually going to block off this vessel. Okay, so now blood can't get through this kidney tissue, and we know that if we can't get perfusion to an organ, what happens? Well, we end up with ischemia. Okay, so we end up with ischemia because we can't get blood through this organ. And this whole thing here is going to clot, right? This blood here isn't really moving, so it's going to clot. You can get thrombosis of these vessels. Okay, and so what is that going to look like when you see a blood vessel that has dying tissue around it, right? Particularly these smaller vessels that have smaller luminal diameter, they're going to have fibrinoid necrosis, right? So you're going to see thrombosis, fibrinoid necrosis of this vessel. The tissues will have ischemia. You're going to get necrosis immediately of the graft, and that graft has to go, has to come out. And again, the way that we minimize this is we make sure that the HLA antigens in the donor match the HLA antigens in the recipient, just like we do with red blood cell transfusions. It's the same thing as we talked about with ABO incompatibility. It's just with HLA antigens. And it can also happen with ABO incompatibility here as well. It can be multifactorial, right? But the big thing is going to be the HLA antigens. We want to make sure that those are matched up.